Hello and welcome to the fourth instalment of Colorectal Live from Johnson & Johnson Institute and Ethicon. I'm Richard Brady, consultant colorectal surgeon at Newcastle Hospitals. Firstly, thanks to everyone who's watched our previous episodes. I've spoken to some of the top names in the profession on a range of fascinating topics, and we've been absolutely thrilled with the online response and engagement. Remember, they're still available on Twitter if you search using the hashtag ColorectalLIVE. But today, I'm really excited to be joined by Professor Gordon Carlson, consultant colorectal surgeon at Salford Royal NHS Foundation Trust, honorary professor of surgery at the University of Manchester, and a professor of biomedical sciences at the University of Salford. Tonight, Gordon will be interviewed on his career, research, clinical interests, and his role in the national plans for intestinal failure services. Thank you so much for joining us tonight, Gordon.
Well, thank you very much for the invitation, Richard.
And remember, you can get engaged and involved too online. Just ask your questions to Gordon using the hashtag ColorectalLIVE. Gordon, let's get to know you a little bit better. You're a consultant colorectal surgeon and a professor with an interest in abdominal sepsis and intestinal failure. What made you become a surgeon, and was there a sudden epiphany?
Well, actually, Richard, I didn't set out to become a surgeon. My first degree was in physiology, and I was interested in renal physiology, and then I decided to become a renal physician. What really changed my career path was entirely serendipitous. I was supposed to go off to New York State University to do an elective in renal medicine with a childhood friend of my father's who was professor there. And it all fell apart for organizational reasons. And I ended up getting packed off to Sweden, where some friends of my mentor who'd taken me through a BSc in trauma physiology was working. And when I came back, my eyes had been opened, and I decided I was far more interested in surgery. I then spent some time with Sir Miles Irving and Lord Les Turnberg, and it struck me at the end of my year as a house officer that I could actually be as physicianly as I wanted as a surgeon, up to a point at least, but I couldn't operate on people if I was a physician, and that set me off on a surgical career path. So, fluke, really.
So tell me about you being packed off to Sweden and your surgical training in Manchester and Newcastle. What were the good bits and what were the bad bits?
Well, as I said, I didn't really want to be a surgeon at the outset. I went off to Sweden, spent some time with Ulf Haglund, and got to do some operations as a medical student, which was fantastic. And that set off a lifelong relationship with Scandinavia in general, surgically. The good bits of my career was after my house jobs, I went off to Newcastle and spent a number of very happy years there, where I came across the late John Farndon. He was senior lecturer in surgery there and just about to go off to Bristol. Unfortunately, I couldn't follow him to Bristol at the time. Bristol was pretty much closed. Everybody, it seemed, had gone from Newcastle to Bristol at that time. So Miles Irving phoned me and asked me if I'd consider coming back to Manchester and applying for an MRC training fellowship. And that for me was the big thing. So I was fortunate enough to get an MRC training fellowship. I spent some time studying nutrition and metabolism in sepsis with the MRC trauma group, who were based in Salford at that time. And that really dovetailed into a career in the parallel clinical specialty of intestinal failure surgery, because I spent most of my time managing patients with complex abdominal sepsis. So the two things fit very, very closely together. And again, Miles was very generous, because in 1997, I'd become an MRC senior clinical fellow. Miles was retiring from clinical practice, and I was very much helped to pick up a huge and nationally prominent practice, which he'd been training me for. So it all kind of fit together very fortuitously.
So, Gordon, it sounds like you have a passion for surgical research, given the background, and that started pretty early in your surgical career.
Yeah.
What's your thoughts on the current surgical research ecosystem in the UK? Is it still important for surgical training?
Well, you're preaching obviously to the convicted, Richard. I wrote my first paper, in fact, as a house officer, based on work that I'd done during my BSc in trauma physiology. I think the surgical research environment has been hampered for many years by comparison with our medical colleagues, because of the difficulty of doing, or at least the perceived difficulty of undertaking clinical trials in surgery, and very very prominent people like Richard Horton have written pretty unpleasant things, actually, about the paucity of clinical trials in surgery. That has changed over the last few years, and I think surgeons now undertake some absolutely first-class clinical trial work, both locally, nationally, and internationally. And I think one of the key developments that I've seen within that setting is the development of the surgical research networks supported by social media. And in particular, the research networks being driven by our trainees. They're able to harness social media to rapidly assemble very powerful clinical trials, answering questions of fundamental importance in the day-to-day delivery of surgical care, and that's absolutely fantastic. However, I think there's also an important role for surgeons that we shouldn't forget in academia, and that relates to much more basic research. I think surgeons are uniquely positioned because of we have patients. We are able to look at what's happening to our patients. We're able to explore the phenotype of surgical disease. But not only are we able to do that, we're able to put tissues in the hands of colleagues who can look at the molecular basis of those diseases. And I think we lose that emphasis and focus purely on clinical trials very much at our own peril. I think our colleagues need us, in fact, to help deliver basic science research. So I've always had one foot in that camp, and I think we have to have at least some surgeons doing the same.
Well, I think the mention of social media is obviously also very important to the very concept of ColorectalLIVE tonight, and it is incredibly important going forward for education and research itself, as you mentioned. Just while we're on the subject of research programs, what about your own major themes in your own research? What has been the most rewarding findings that you've made to date?
Well, most of the research that we've been undertaking over the last 20 or 30 years has focused on sepsis, the effect of sepsis on nutrient metabolism, particularly at the cellular level, and how patients are able to utilize the nutrients that we give them when they're septic and catabolic, and why we're unable to get patients into an anabolic state until we've dealt with the source of the sepsis. And in doing so, we've been very lucky to have funding from bodies like the Medical Research Council. And within that envelope, we've done looking back, some fairly hair-raising things like giving endotoxin infusions to healthy volunteers. I was one of them myself, I should point out, and looking to see whether we can model the pathophysiology of sepsis in healthy volunteers in a predictable way to see what effect it has on nutrient metabolism and also on the induction of pro-inflammatory cytokines in skeletal muscle. So there's a body of work there that I've been involved in for over 20 years and been very proud of. We've also done some quite interesting stuff on the gut barrier, again in critically ill patients. And some of the work there that our unit has been perhaps again most proud of is the demonstration that bacterial translocation, the passage of bacteria across the apparently intact gut epithelium, does not, as previously been thought, involve paracellular channels, but actually an active process by which bacteria are recognized and are able to gain access to the enterocyte cytoplasm, particularly under circumstances where the enterocyte is depleted of fuel substrate and especially glutamine. That kind of work got colleagues like Ed Clark a Patey Prize and also resulted in some very high impact factor publications in major international journals like gastroenterology. So we were very proud of that.
Well, it sounds like I probably wouldn't be first in the queue for some of that research program, Gordon, to be honest. But it's good to have you online. I just want to remind the audience that if you're watching live and you have a question for Professor Carlson, we'll always welcome your involvement. So please tweet your question along with the hashtag ColorectalLIVE, and we'll come to those before the end of the show. Gordon, let's focus on intestinal failure. I note that you've recently been awarded a CBE in the Queen's New Year's Honours List for services to general and intestinal failure surgery. Can you tell me how you developed that particular passion?
Well, as I said earlier, I came back from Newcastle and found myself doing research into nutrient metabolism in sepsis. And of course, most of the patients that I was studying had what we would now call acute severe intestinal failure. These are patients who have complex nutritional and metabolic problems who require intravenous feeding. And therefore, I began to get involved in the clinical management of those patients because, of course, I was in a surgical training pathway. And as my training through lecturership and senior lecturer roles developed, I became more and more involved personally in the clinical management of those patients. And of course, that in turn, those patients formed the substrate for a lot of the research that I was doing. So it was a perfect match from my point of view. And of course, I've been involved in the management of this problem pretty much ever since 1997.
So it sounds, going back in your original introduction, that Miles Irvin was a key element of your career, and it looks like a major success of the apprenticeship model, if I may say so. So how, for our general audience, can you define intestinal failure, and what kind of patients develop this, and when are they eventually referred to a surgeon with an expertise like your own?
Okay, so I think it's important to recognize that if you mention intestinal failure to a North American physician or surgeon, they will recognize that you're talking about a stable patient with short bowel syndrome who's either on long-term parenteral nutrition or maybe having a small bowel transplant. And of course, we recognize that too in Europe. However, in Europe, we also recognize a more acute stage of intestinal failure. The unifying concept is the fact that one cannot survive without artificial provision of either food or fluid and electrolytes, and in fact, usually both. So, an acute intestinal failure condition is a condition in which a patient is dependent on intravenous feeding, but it's usually a reversible condition. Chronic intestinal failure is not usually reversible, except by intestinal transplantation or some much more specialized techniques that we'll get to later. Um, you asked me about when patients are referred. So in the United Kingdom, patients with acute severe intestinal failure, these patients usually have open abdomens, intestinal fistulation, complex abdominal sepsis, and they're dependent on parenteral nutrition. And they're referred to centres like the centre I and my colleagues run in Salford at various points along their journey. That depends to a very considerable extent upon the expertise, the enthusiasm, and the resources of the centre that are already treating them at the time. So we'll see some patients who are delivered up to us pretty much sorted, just needing reconstructive surgery. And we'll see other patients who, I'm afraid, are transferred in a really quite parlous state of critical illness who need active management of abdominal sepsis and time on the intensive care unit, management of organ failure, etc. So there's a wide spectrum of disease that we end up treating.
So how big is the problem, Gordon? How many people suffer from the condition? And do you think the incidence is increasing or decreasing? Are we getting better or worse at surgery?
Well, that's an extremely difficult question to answer, and it's a bit of a Rumsfeld type question because we only know what we know we know. Patients who have, for example, a laparotomy where a lot of dead bowel is found, and a surgeon makes a decision that this patient's not going to survive and closes the abdomen, they don't even register in the figures. So we don't know about patients who might potentially be salvaged but are not offered the opportunity. Equally, there may be patients out there getting intravenous feeding who don't need it. All I can tell you is that when they look to start establishing a national network, the Department of Health did a piece of work at the outset, and their estimate was that there were perhaps 10 to 20 patients per million population at any one time in the United Kingdom with acute severe intestinal failure. That is, patients who had been in hospital continuously and who had been on parenteral nutrition for at least 28 days continually. So we're talking about maybe 600 to 1,000 patients in the country. Is that increasing? My impression is it is, and it's increasing because we're doing bigger and more complex operations on elderly and more frail patients that sometimes go wrong. And also because our colleagues in the critical care units are better at salvaging these patients. So they then deliver to centres like ours patients with intestinal failure who in the old days would have just died in the acute setting.
So clearly, we've got quite a way to go to educate and record these cases much better. How do you treat patients with intestinal failure? And can you tell us a little bit, for the generic audience that are joining us, about the SNAP algorithm?
The SNAP algorithm, I think, originally arose from the musings of my colleague Nigel Scott, who worked for a while in Salford. Nigel, I think, without putting too many words in his mouth, looked at ATLS and realized that since you can summarize the problems in the order in which they're most acutely life-threatening for the injured patient, we can also do the same for patients with complex intestinal failure. And therefore, you can be served up a patient with an open abdomen, with fistulas all over, who is acutely unwell, unstable, with complex nutritional and metabolic problems. But actually, the management principles of however complex the problem is, the management principles are actually very simple, and they are S, sepsis, N, nutrition, A, anatomy, and P, procedure. And you cannot address a patient's nutritional problems while they remain actively unwell with sepsis. We know that, and some of the work we did showed that. In fact, that's been known, since the time of Hippocrates. The bottom line is you can't address a patient's catabolism except by treating sepsis. You then have to address the nutrition once you've dealt with the sepsis, and there's no point worrying about what the anatomy of the problem is, except as much as is needed to deal with sepsis. Finally, we shouldn't be planning a reconstructive surgical procedure for patients with intestinal failure until we've fully treated their sepsis, fully addressed their nutritional deficiencies, and we know exactly what the anatomy of the problem is that we're going to try and reconstruct. So although this is a deceptively simple concept, it's as relevant now as it was 20 odd years ago when it was first coined.
Well, I think Hippocrates hopefully didn't have to deal with teleclinics in his day. But can you tell me about the most common error that we have in the management of intestinal failure? Have you any tips or tricks, and what are good rules of thumbs in the management of that condition?
Well, actually, by extension, Richard, it follows logically that the most common problem is to forget the simple things, and it's to forget the need to eradicate sepsis and make sure the patient is fed adequately. And when you do plan a reconstructive operation, make sure the patient is as fit, and that means psychologically as well as physically, as you can possibly get them. And the problem that we see, I'm afraid, fairly frequently is that our colleagues get press ganged almost by their patients into trying to sort out what is undoubtedly an appalling problem. You know, to lie there with your abdomen open and an intestinal fistula, it must be extraordinarily difficult to tolerate. But the truth is, rushing a patient back to theatre when they're frail, septic, ill, is not going to allow you to have a good outcome. So the key tips are: sit on your hands until the patient is as well as you can get them. Have a big team around you to address all of the patient's needs. This is a multidisciplinary game par excellence. And in fact, we were doing this as a multidisciplinary practice long before MDTs for cancer surgery developed. And then finally, when you do go to operate on a patient, you go mob-handed and you set as long as you need aside, and you stage reconstruction if necessary to get the best outcome. So those are my top tips, as it were.
Well, they're really good top tips, and I'm sure that will ring true to many situations and to many colorectal surgeons. What's new in the field of intestinal failure in terms of treatment and surgery?
I think I can divide this into two categories, Richard. Firstly, I think over the last 5 to 10 years, we've become far better at managing complex abdominal sepsis. I think, have emerged from a time when just about anything that led to abdominal sepsis resulted in an open abdomen, and several weeks on the intensive care unit with an open abdomen. I think we've become far more selective now in the way we use the open abdomen to manage sick patients, and that in turn has resulted probably in a reduction of patients with secondary intestinal fistulation. I think the use of mesh-mediated traction to reduce the size of the abdominal wall defect that you need to reconstruct when you do put patients back together again has been a hugely positive development in the acute setting. I think in the more reconstructive phase, the big developments that I've seen, particularly over the last few years, and which, to be fair, we're still working on perfecting, are the development of fistuloclysis. That's a recognition that not all of our patients need to be fed intravenously. If you've got an open loop of bowel in an enteroatmospheric fistula, you can cannulate the bowel and you can feed the patient directly into their exposed bowel simply by infusing enteral feed. In the old days, we used to have to remix chyme and collect chyme and mix it with feed. And I have to say that British nurses hated doing that. They really did. And it led to all sorts of complex ethical problems about where you stored their bowel effluent and what happens if you gave somebody else the wrong bowel effluent. You don't need to do any of that. You can infuse enteral feed. And we and others have shown you can do that very satisfactorily. And then the other big developments, I think, are intestinal lengthening surgery for patients with short bowel. We know that there's a proportion of patients who don't need transplantation. You can undertake a variety of plastic procedures to convert the width of the bowel to increase length, which will then dilate and allow them to wean from parenteral nutrition. And then finally, teduglutide and other drugs which improve adaptation. And the big question going forward is whether those techniques can be combined for greater efficacy to improve intestinal plasticity. And I think that's a word you're going to hear a lot more of over the next few years.
This is a good point to ask everyone, to remind everyone to get engaged in Colorectal Live, and we'll take some of your questions before the end of tonight's show. Now, let's talk about a little bit more about your national role in intestinal failure services. Can you tell me about that role as an advisor, and what has your work exposed regarding the current national IF situation?
I got involved in this in 2008, Richard, when a group of physicians had got together and reported their concerns to the Department of Health about inequalities in the provision of home parenteral nutrition. And that kind of snowballed into a report which sought to address inequalities in the provision of surgical care, which was a bit of a pity because there were a number of problems with that report. And in fact, there was relatively little surgical input into it. John Black, who at the time was president of the Royal College of Surgeons of England, asked me to liaise with the Department of Health to try and improve that aspect of the report. And I've been involved with the Department of Health and then NHS England pretty much ever since. The current state of play for intestinal failure resource is this. We have two units, our own in Salford and one at St Mark's in London, which are large centres and have had the benefit of national funding, top sliced from the Department of Health budget to an eye-watering tune for several years. And I would like to think we manage intestinal failure extremely well, and we should do, because we've been very well resourced to do it. There are, however, a number of other centres up and down the United Kingdom which also manage intestinal failure extremely well. The difference is they've not been adequately resourced to do it, and they've had to scrape the money together from local commissioners and try and build multidisciplinary teams without the benefits that we've had. But they're doing a great job, and I think those centres need to be supported. There are a lot of other centres which really struggle to manage one or two patients a year, and in most of those cases, the patients that they're managing developed intestinal failure as a result of complications that developed in their own care. So colleagues are understandably reluctant to refer those patients onto other centres, but they don't have the expertise, they don't have the multidisciplinary team, they don't have the resources to manage those patients. And I think the drive is to try and get those patients out of centres where there are concerns about the quality of care that those patients may have, the amount of time colleagues would have to spend looking after them, and put them in adequately resourced centres as near to their home as possible, where those patients will get high quality care provided by teams trained and resourced to give it.
So it sounds like an amazing volume of work to be done, Gordon, and I think the nation thanks you for engaging
It's
in
an
this
ongoing project.
with advice. So another area of keen interest for colorectal surgeons, which is partially linked, is your involvement in guidelines and research surrounding anastomotic leakage. Can you summarise your advice to colorectal surgeons when faced with that high-risk anastomosis?
Well, I undertook a piece of work with Des Winter and Bob Steele on behalf of ACPGBI and ASGBI to produce some joint guidelines. And the purpose of those guidelines was to support our colleagues and to support our patients. And it was to define what makes an anastomosis high risk and to make sure that surgeons knew that under some circumstances, they were inevitably going to be undertaking anastomoses at higher risk of leakage than one would hope to see. And I think the take-home message is that what makes those anastomoses high risk are very clearly set out in those guidelines. I won't go through it today because we don't have enough time, but the most important things are actually very closely related to what we were talking about for intestinal failure, like malnutrition and active sepsis. Um, but most importantly, the thing that emerged from that guideline was our involvement of patient groups in developing that guideline. That was something that Norman Williams actually seized on in his foreword. I think it's important that we involve our patients in our decision making. So the advice that came out of that guidance is, if you're going to construct an anastomosis under circumstances which may be higher risk than normal, firstly, don't do it unless you absolutely have to. And secondly, if you are going to do it, then you should discuss it with your patient and make sure they understand that, and make sure that they have made an informed choice to proceed with a course of action which may expose them to higher risk than normal. Doing that will protect our patients, and most importantly, actually, will protect us from criticism in future.
So a truly remarkable body of work, Gordon, and we could spend really all night exploring all of your interests, but I'll not keep you online for that length of time. We've come to that part of the interview, which I'm sure you are eagerly anticipating, our quick fire questions. Now, the rules here are that you answer the questions in 1 or 2 sentences. So let's kick off with, what's been your best single day at work?
Best single day at work, the first massive abdominal wall and IF reconstruction that myself, my colleagues, and a cast of thousands, including some plastic surgeons, did. It took 16 hours to undertake that case. It had never been undertaken before in the United Kingdom, but we left with a real sense of achievement, and the patient is alive and well with an intact abdomen 5 years later.
Well, I think after 16 hours of work, some would say that that's not your best day at work. But irrespective of that, what's been your single worst day at work?
My single worst day at work, Richard, occurred when I was a senior trainee in a large district general hospital, and I won't mention the hospital. I was left looking after someone who I could see was visibly deteriorating, and I could not get my senior colleagues, either surgeons or anaesthetists or intensivists, interested in this man at all. He was not an old man, but I could see that things were heading only in one direction. And the nightmarish quality of watching this unfold and not being able to do anything about it haunted me actually for years afterwards. And what I took from that is that when our colleagues need us, particularly when our junior colleagues who are holding the fort for us need us, we've got to listen to them and be able to support them.
Wise words indeed. Now, who inspires you, Gordon? Where do you get your daily inspiration from?
Well, at home, my wife and kids, obviously, I have to say that. At work, actually, it's my trainees and also my younger consultant colleagues. We're very fortunate to have amassed a fantastic, competent, bright, energetic group of young colorectal colleagues, or some of them not so young now, but younger than me anyway, who are thoughtful, who are questioning, and they keep me on my toes every day. So my desire to keep one step ahead of them continues to inspire me.
Well, you'll certainly have gained some points from that answer, Gordon. Can I ask you what your favourite saying or wisdom is?
Yes. So all surgeons have to compromise at times. Make your compromises outside the operating theatre. In other words, when you're going to compromise, make the compromise part of your treatment plan and discuss it with the patient. Don't compromise in the middle of an operation. Do not leave the operating table until you have carried out your surgical plan as well as you can possibly do. It'll be okay in the middle of an operation, will never be okay. So that would be my wise saw, as it were.
Got it. And what's the worst piece of advice you've ever been given?
I was given a piece of friendly advice by a professor of gastroenterology many years ago, who told me that research was for physicians and surgeons, just existed to cut things up. That was a piece of advice I discarded. fortunately, and that individual's since retired. But I suspect he did untold damage for a period of time. So bad advice, and didn't help anybody.
Sounds like you're being generous calling it friendly, Gordon. But what kind of books do you read, and what's your favourite author?
I have very wide-ranging reading habits, Richard. I read for fun. I read Grisham. I read George R. R. Martin. But I also enjoy reading political biography. My favourite author, actually, at the moment is probably Misha Glenny, and his account of the history of the Balkans is horrifying and riveting all at the same time. I warmly recommend anybody to read it if they want to know how things can go so badly wrong in a civilized country.
How do you switch off otherwise?
I play guitar, and I apologise here and now to some of my colleagues who I've subjected to my guitar playing at a variety of social events. I like to try and get to the gym, maybe 3 or 4 nights a week, and I do like fine wine.
And what would you like to be most known for at the end of your career?
For being hardworking, for being relentlessly patient focused, and for being uncompromising.
Well, there's some great answers, Gordon, and thanks very much for putting yourself through our quick-fire questions. And it's been really fascinating, the entire interview. But as we're approaching the end of our chat, I wanted to ask a couple more questions that we've received from our audience watching live. So this is a question just in from Marie. Are there international staffing guidelines for IF centres?
There are no international staffing guidelines. What I can direct Marie to is a document published 3 years ago by the European Society of Colorectalology, which does set out in some detail the level of resource needed to successfully provide effective care for intestinal failure. There are also some national standards within the UK. It's very difficult, I think, to see how we could have international standards, particularly since we all approach this problem at the moment, at least, in so many different ways.
Great answer. And we have another question from Peter. How much extra length can you get from intestinal lengthening procedures, and what is their success rate at weaning patients off TPN?
Peter, that's a fantastic question. So the answer to that question is you can roughly double the length of the small intestine using a technique such as the STEP procedure, serial transverse enteric plication. But the important thing, I think, that people forget quite often when they talk about these techniques is they're not one-offs. And these techniques develop from paediatric surgery, who would often be prepared to take a child back to theatre over a series of years, maybe 2 or 3 times. So theoretically, you can step the length of bowel up several fold, provided you've got patients who you're able to take back on several occasions, maybe 2, 3, 4 years apart. So you can easily double or triple the length of small intestine.
Well, they're fantastic answers, Gordon, and it's been a great insight and wide-ranging interview, and I'm really grateful for you to spend time with us tonight. Thank you.
It's a pleasure.
Now, I'll be back with Colorectal Live again soon, when I'll be joined by Professor Pete Sagar on the 3rd of September for a discussion on his specialist subject, Excellence in Surgical Training. Keep following us on Twitter for more in the meantime, and thank you again for watching tonight's Colorectal Live.